Hi, my name is Tracey Childs, and I'm a general and colon and rectal surgeon at St. John's. I'm currently the chief of surgery at St. John's. I am the past chief of staff. I've been here for 30 years in all sorts of different capacities. I started out in private practice 30 years ago. I've always worked within a 5-block radius, so any of my patients could stand out on Santa Monica Boulevard and yell for me, and I would hear them. I'm double boarded in general surgery and in colon and rectal surgery. I do benign and malignant general and colon and rectal diseases. I specialize in colon cancer and rectal cancer. I also treat pelvic floor disorders. So I treat rectal prolapse, which nobody likes to talk about, and you can't even imagine. It's more common to talk about urinary or urogynecologic issues, but that's the anterior compartment or the front. And what I deal with is the same thing in the back. And so there are special surgeries that I do that will reconstruct the posterior compartment and keep everything up inside where it belongs. And that can all be done minimally invasively also. And I work in concert with our urogynecologist, Dr. Lauren Kadish, and oftentimes we'll do combined surgeries. So a patient will have issues with uterine prolapse or vaginal ball prolapse as well as rectal prolapse, and we both work together and share the same space and the same technology, and the patients do great, go home, and everything's put back where it belongs. I used to do a lot of breast cancer surgery and skin cancer surgery. Patients find me either by being referred by another physician, a primary care physician, oftentimes a gastroenterologist, but I take care of a lot of members of people's families. I may have operated on somebody for something and then their father or mother develops colon cancer and they're in my office. So once I meet somebody, I try pretty hard to gauge what style they're comfortable with. I'm a wear my heart on my sleeve, speak fairly directly kind of person. I don't think that people can figure out what you're trying to say if they don't understand you. And my patients are all partners in the process. And so from the get-go, I make sure that we're on the same page. And I can tell you a story later about a patient who walked into my office with a rectal cancer, and he brought his wife and he sat right down in front of me and said, I am not going to have any surgery, I'm not going to have any chemotherapy, and I'm not going to have any radiation therapy. And his wife was an angel and just let him sit there and emote. And I said, I hear you, and we're going to work together to figure out how best to take care of you. And we did exactly that. I'm a big communicator. I speak with my hands, I speak with pictures, I make sure they understand what's going on. So we go through that educational part in the first aspect or the first time that we meet. I believe that you have to do things in baby steps sometimes. I mean, I make sure that patients understand that for the most part, their cancer is not like a ticking time bomb, that we have the time to take the time to make sure that they're comfortable with the process. And that's really important to me. And I find that patients feel like they're in more control, because when you have a cancer diagnosis, all of a sudden all your control goes out the window, right? So if I can help my patients feel and take back part of that control, it's better. And oftentimes there's options. I'm also a no drama person, so I will try to peel people off the ceiling if they're coming in feeling like there's a hurry for something. And so then the next thing is to make sure that all the staging is done, all the imaging is done, all the lab testing is done, and we know exactly what we're dealing with. And then we make a plan. And for colon cancer, it's oftentimes surgery first. For rectal cancer, it's oftentimes I meet the patient or I make the diagnosis, and then I send the patients off for imaging. And if their rectal cancer is a T3 tumor, meaning that the risk is high enough that there'll be spread of the disease into the regional lymph nodes, then that patient will end up getting chemotherapy along with radiation therapy and then full chemotherapy before I ever see them again. And then so it may be 6 months before I see them again. So I've started them on their journey and then they come back to me. And the bulk of patients will end up having surgery. Some of that is what we call organ preservation surgery or restoring continuity, meaning we take out the rectum, part of the rectum, and we create a neorectum using their colon, or they may end up with having the whole bottom end taken out and a permanent stoma. And I have never met anybody who says, yay, I get to have a stoma. So it's always, again, another journey or a pathway in helping people adjust to what their new circumstances are going to be. And they have to do it in their own time. Treating gastrointestinal cancers, including rectal cancers, is a multidisciplinary approach. So as I said, the patient may come to me from a gastroenterologist, or they will come to me and I will make the diagnosis, and then I have to call on my colleagues, both the gastroenterologists, because this patient may never have had a colonoscopy before, or the radiation oncologist, the medical oncologist. We have oncologic psychiatrists now, so we have mental health specialists who help us manage and support our cancer patients. And so it's very multidisciplinary, and I'm just one part of the program. And interestingly enough, the way rectal cancer treatment has changed is that there are a very small group of rectal cancer patients who, after they've seen me, after they get their chemo radiation, after they get their post-treatment imaging, it looks like the tumor is totally gone. And in the past, we would have operated on that patient, possibly with a permanent stoma, and given them the great news. It worked. There was no evidence of any residual disease. You're cured, we hope. But now we may not have to do that. Now there's a small group of patients who may qualify for never having to have surgery. And yeah, am I working myself out of business? Yes, and with pleasure. You know, if we can change the way that rectal cancer is being treated. It doesn't account for everybody, but it's a game changer. Here's the other game changer, is that when I started in surgery, everything was open. And then we moved to laparoscopic or minimally invasive surgery, which is what we called it at the time. And oftentimes the patient would still have some type of an incision as an extraction site, with an increased risk of post-op hernias. And now I do almost all of my colorectal surgeries, as well as some other intra-abdominal surgeries, as robotic-assisted laparoscopic surgery. So it was an amazing thing as a late-stage surgeon to be able to learn a whole new set of skills, and I think master those skills and be able to share them with my patients, because it's a game changer. And it's not only the technology that's a game changer, but it's our approach to minimally invasive surgery with what we call early ambulation, early feeding, you know, getting no narcotic pain medicines, and preparing patients for an enhanced recovery pathway like that takes a lot of work on the front end. So that gets back to communicating with patients and teaching them and having them buy in and partner with you, so that when I tell them in the office that after your surgery, you're probably not going to need any narcotics. We're going to manage you on ibuprofen and Tylenol. And they're like, what? You know, and some of them are like, are so happy because they're so concerned about narcotic addiction. Where I used to have a patient that would have a surgery and they'd be in the hospital for 6 to 10 days. Some of those patients are going home on post-op day 1, and when they come back to the office, they're driving themselves 1 week after surgery. And it's an amazing thing. I use a patient engagement app called Twistle. I've been using it probably for 6 or 7 years now. I was a pilot. When it first started, I think it got rolled out to the spine group or some orthopedic group in Providence, and I kind of thought this would be perfect because there's so much preoperative education and things you have to remember when you're having bowel surgery. You have to pick up your bowel prep, you have to pick up your antibiotics, you have to start the bowel prep at a certain time and take the antibiotics 3 times on a certain day. So Twistle is a patient engagement app, and it is customized to my content, and it is customized to a timeline where once we put in the date of surgery, it will start texting the patients who sign up 2 weeks ahead of time. Did you remember to pick up your Hibiclens? Did you remember to pick up your bowel prep? Did you pick up your antibiotics? Have you been getting exercise? Did you quit smoking? Which that's my favorite because most of my patients don't smoke, and they'll text me back and say, I don't smoke. You know, I'm like, it's okay, it's okay. It's just the app. When the patient leaves the hospital, this is the best part. The app texts the patients 5 questions for several days after surgery, like, do you have a fever? Is there any redness or drainage? Are you eating? Do you have intolerable pain? And if the patient answers off the default, I immediately get a text message so that I can respond right away to them. I know that other service lines, there are other people who manage the Twistle. If I have a patient who's not comfortable, you have to have a smartphone or a smartphone or a smart device. If the patient, say I have an 85-year-old person who's not comfortable with that, usually their family member or caregiver wants to be involved. It makes them feel like you're checking in. And the best part of it is the messages don't fall through the cracks. They don't call the office and leave a message so that I don't get, till Monday if it's a weekend. I get it in real time and I can respond. If they have any questions, it saves them trips into the emergency room, because if they're concerned about something with a wound or a dressing, they can take a picture and upload it onto their Twistle, and then I can see it and say, oh yeah, that happens a lot of times, don't worry about that. As I said, I'm a big communicator, and I welcome questions that anybody might have about colon cancer, rectal cancer, abdominal wall reconstruction, which is also known as hernias, enhanced recovery pathways, robotic surgery, laparoscopic surgery, what we have to offer here at Providence St. John's in terms of multidisciplinary approaches to colon and rectal surgery, all of those things. And because we have the ability to do both in-person and virtual visits, accessibility isn't a problem.